Shortness of breath is a common presentation that we see in the emergency department on a daily basis. In fact, 3% of all presentations to the emergency department in Australasia will be for shortness of breath, and approximately 2/3 of those presentations will require hospital admission. When you're taking a history from the patient, there are a number of cardinal respiratory symptoms that you need to ask about that include cough, sputum production, hemoptysis, dyspnea, wheeze, chest pain, fever, hoarseness, and night sweats. In the patient who presents with shortness of breath, you need to recognise the signs and symptoms consistent with severe respiratory distress. These include inability to speak, diaphoresis, tripod positioning of the patient. Now this is where the patient stands or sits leaning forwards, supporting the upper body with the hands on the knees or another surface. And this position optimises the mechanics of respiration by taking advantage of the accessory muscles of the neck and upper chest to get more air into the lungs. Other signs of respiratory distress include extreme tachypnea, with respiratory rates greater than 30 breaths per minute, hypoxia, with pulse oximetry readings less than 90%, accessory muscle use in intercostal recession, tracheal tug, stridor, and a silent chest on auscultation. This is a particularly important finding in the patient with severe asthma. Other signs of severe respiratory distress can include tachycardia or bradycardia and pulsus paradoxus. Now this is an abnormally increased fall in the blood pressure of more than 10 mm of mercury on inspiration. The paradox is that you can detect heartbeats on auscultation of the chest that are not palpable at the radial pulse. This sign is seen in several conditions that include cardiac tamponade, pericarditis, croup, and obstructive lung disease such as asthma and COPD. While most patients who present to the emergency department with shortness of breath will have respiratory or cardiac causes for their presentation, you need to have a more complete differential diagnosis for their presentation. You should consider the following in your differential: asthma, COPD, acute pulmonary edema, acute coronary syndrome, valvular heart disease, pneumothorax, pneumonia, pulmonary embolism, airway obstruction, trauma including chest wall injuries and smoke inhalation, neurological causes such as spinal cord injury, muscular dystrophy, Guillain-Barré syndrome, and stroke, endocrine causes such as diabetic ketoacidosis, metabolic causes such as metabolic acidosis from sepsis, toxicological causes such as salicylate toxicity, hematological causes such as anemia, gastrointestinal causes such as massive ascites, and psychiatric causes such as acute anxiety. In patients with shortness of breath, you will need to organise investigations to help you narrow your differential diagnosis. Investigations to consider should be dependent on your initial differential diagnosis and may include a chest X-ray. This is an exceedingly important investigation as it will give you a lot of information such as the presence of consolidation, which is seen in pneumonia, hyperexpansion of the lungs, which is seen in asthma and COPD, interstitial edema, which is seen in acute pulmonary edema and ARDS, pneumothorax, rib fractures and lung contusions following a traumatic chest injury, and pleural effusions, which is seen in congestive cardiac failure. Lung ultrasound. This is a relatively new bedside assessment tool for the investigation of the patient with shortness of breath. It can be used to diagnose a number of conditions including pneumothorax. The sensitivity and specificity for pneumothorax using this test is much better than chest X-ray, and the findings include loss of lung sliding and the absence of the seesaw pattern in beam mode ultrasound. Ultrasound can also be used to diagnose pulmonary edema. This shows the presence of multiple lung rockets and pleural effusions, and this is highly suggestive of congestive cardiac failure. Basic echocardiography is also useful, can show a dilated RA and RV suggestive of pulmonary embolism with right heart strain. Pericardial effusion suggestive of pericardial tamponade can also be elucidated, and you can also use ultrasound for basic assessment of contractility of the heart, which is useful for diagnosis of heart failure. Pulse oximetry. This is a very useful non-invasive bedside test that gives you information about the oxygenation of the patient. Arterial blood gases. This gives you a lot of useful information such as the presence of hypoxia, hypercarbia, which is seen in type 2 respiratory failure, the presence of a metabolic acidosis that may be driving the patient's presentation of shortness of breath. Spirometry. While this is a useful test for determining causes of chronic shortness of breath, its usefulness is limited in the emergency department. Its main role is in the assessment of severity of asthma. In patients with a peak expiratory flow rate less than 50%, this is a predictor of the need for hospital admission. Complete blood count. Look for an elevated white cell count in patients with sepsis and low hemoglobin in patients with anemia. You need to be aware that elderly patients and immunosuppressed patients may not present with an elevated white cell count in the presence of sepsis. Immunosuppressed patients on chemotherapy may have evidence of significant neutropenia in the presence of significant sepsis. C-reactive proteins. These can be a useful marker in patients with sepsis. Blood cultures. These should not be a routine test on patients who present with an infection. Indications for taking a blood culture would include patients who have severe sepsis or septic shock and high-risk patients. High-risk patients are nursing home patients, immunosuppressed patients, alcoholics, diabetics, and intravenous drug users, and these groups of patients are at a higher risk of gram-negative sepsis or sepsis related to atypical organisms. D-dimers. The D-dimer is a useful test in excluding the diagnosis of pulmonary embolism in patients who are low and intermediate risk, and we'll talk a little bit about risk stratification a little bit later in this talk. ECG. Features to look for include evidence of ischemia and infarction. You should also look for arrhythmias such as atrial fibrillation that may present with shortness of breath. A troponin is useful in the diagnosis of acute coronary syndrome. CT pulmonary angiogram is used in the diagnosis of patients in whom the diagnosis of pulmonary embolism is suspected. Indications are in patients who are low to intermediate risk with a positive D-dimer or in high-risk patients. Ventilation perfusion scans are an alternative test to the CT pulmonary angiogram when you're making the diagnosis of pulmonary embolism. The management of patients with shortness of breath is dependent on their presentation. Interventions to consider using include the use of supplemental oxygen. Invariably, most patients with shortness of breath will require oxygen therapy. This should be used in patients who are hypoxic. You need to be careful using oxygen in patients with COPD with type 2 respiratory failure and hypercarbia, as it may depress their respiratory drive. In patients with type 2 respiratory failure, you should aim to achieve oxygen saturations between 88 and 92%. The use of oral airways such as the Guedel airway and nasopharyngeal airway to open up the airway in patients with a depressed level of consciousness that are not able to maintain an airway. High flow humidified oxygen therapy via nasal cannulae. This is a relatively new concept and can be used in patients with hypoxic respiratory failure to improve their oxygenation. At higher flow rates, a small degree of positive airway pressure may be achieved, and studies suggest that this may be up to 10 centimetres of water. Non-invasive ventilation, CPAP and BiPAP. Both of these modalities can be used in patients with respiratory failure, both type 1 and type 2 respiratory failure. BiPAP is commonly used in patients with exacerbations of COPD, asthma and pneumonia. And CPAP is commonly used in patients with acute pulmonary edema. Invasive mechanical ventilation. This is used in patients with severe respiratory failure who are too sick for or have failed non-invasive mechanical therapy. ECMO. This is also known as extracorporeal membrane oxygen therapy. This is an intervention that can be used for refractory cardiogenic shock and severe respiratory failure in whom mechanical ventilation is failing. It's similar to placing a patient on cardiopulmonary bypass and is only used in patients where all other interventions have failed. It is most commonly used in severe refractory ARDS. Presumptive management of patients. In patients who present with severe respiratory distress, it may be difficult to initially work out exactly what the underlying pathology is. In these cases, it is not uncommon for us to start therapies for multiple conditions in the initial resuscitative phase. For example, a patient in severe respiratory distress has a history of COPD and congestive cardiac failure, and the initial management of this patient may include therapies directed at both of these conditions. Now that we have discussed the initial management of patients with respiratory distress, we should consider some of the common emergency department presentations for shortness of breath, how they present, what investigations to order, and how to manage each of these problems. Asthma. This is a chronic reversible inflammatory disease. It's characterised by decreased expiratory flow and airway obstruction. There's air trapping and barotrauma. And in severe cases there is decreased venous return due to obstruction, which results in hypotension. Patients with severe asthma will present with muscle fatigue and respiratory failure, which results in hypoxia and hypercarbia. As mentioned previously, bedside spirometry can predict the need for hospital admission, with peak flow rates less than 50% highly indicative of the need for admission. Pulse oximetry is also a useful indicator of a hypoxia and type 1 respiratory failure. Arterial blood gases should only be performed in patients with severe respiratory distress. In patients with mild to moderate disease, non-invasive monitoring with pulse oximetry is sufficient. The chest X-ray usually just shows hyperinflated lungs consistent with chronic obstructive disease. It should be used to look for complications such as pneumonia or a pneumothorax. The cornerstone of management is with bronchodilator therapy and steroids. Bronchodilator therapy is with aerosolized salbutamol. Now, the bioequivalence of oral versus intravenous steroids is similar, so oral prednisone is the preferred medication. Intravenous hydrocortisone should be used in patients who are unable to tolerate oral medications. Now, these are usually patients who are critically unwell and ventilated, this being either non-invasive or mechanically ventilated. In severe cases of asthma, other interventions can include the use of ipratropium, intravenous salbutamol, magnesium, ketamine, adrenaline, and inhalational anesthesia. COPD. This is also a chronic inflammatory obstructive disease. It differs to asthma in that it is a progressive disease that is not completely reversible. There are two major types of presentation, the blue bloater and the pink puffer. Acute exacerbations present with increased shortness of breath, and infective exacerbations may present with increased sputum production and increased sputum purulence. Management of these patients is with aerosolized salbutamol and ipratropium and the use of steroids. Antibiotics are indicated if there is evidence of an infective process such as fever, increased sputum production, or purulence of the sputum. Frequently, patients with moderate to severe respiratory failure are placed on early BiPAP. This intervention has been effective at reducing intubation rates if instituted early. Pneumonia. The symptoms of pneumonia include fever, productive cough, shortness of breath, and pleuritic chest pain. There should be signs of consolidation either on clinical examination or on the chest X-ray. You need to be mindful that not all pneumonia will be seen on the chest X-ray, and in fact, the sensitivity of the chest X-ray for consolidation is only 40 to 60%. As discussed before, you should only get blood cultures in patients with severe sepsis and septic shock, or in patients who are at high risk for atypical organisms. Sputum cultures, while not always useful in the emergency department, should always be taken as these will guide antibiotic therapy at a later stage. Antibiotics should be prescribed and given as soon as possible. They should be given according to the local hospital guidelines. In general, patients with pneumonia should be treated with a macrolide such as azithromycin and a cephalosporin such as ceftriaxone. In patients with immediate penicillin hypersensitivity, A fluoroquinolone such as moxifloxacin can be given as a single agent. In patients with septic shock who are going to the intensive care unit, an anti-pseudomonal cephalosporin or gentamicin should be added. Patients with severe pneumonia are also at risk for staphylococcal sepsis, and you should cover for MRSA with vancomycin. Pneumothorax. A pneumothorax is an abnormal collection of air in the pleural space. It commonly presents with pleuritic chest pain and shortness of breath. A tension pneumothorax is a pneumothorax that presents with cardiovascular collapse. It may also be diagnosed radiologically with evidence of mediastinal shift without cardiovascular collapse. The common findings in a patient with pneumothorax include tachypnea, hypoxemia, tachycardia, tracheal deviation, hyperresonance on percussion, and jugular venous distension. Now, the management of a pneumothorax is dependent on its size and whether there is evidence of tension. The treatment of a tension pneumothorax should be immediate decompression with either a needle thoracostomy or a finger thoracostomy for needle failures. Tension pneumothorax should always be treated with a formal chest drain. Small pneumothoraces that have minimal symptoms can be managed expectantly, and moderate and large pneumothoraces with no evidence of tension can be treated with mini chest drains. These are also known as a pleurocath. Acute pulmonary edema. This is the most common cardiac cause for shortness of breath. Symptoms include orthopnea, paroxysmal nocturnal dyspnea, and leg swelling. Signs of congestive cardiac failure include tachypnea, jugular venous distension, displaced apex beat, a gallop rhythm and third heart sounds. There may be signs of pulmonary congestion with crepitations on auscultation of the chest, and there also may be right upper quadrant tenderness consistent with liver congestion, in addition to pitting edema of the lower limbs. The chest X-ray will show cardiomegaly, a diffuse interstitial infiltrate with upper lobe diversion, and the presence of curly B lines. The ECG may show signs of ischemia or infarction, or it may show evidence of a cardiac arrhythmia such as atrial fibrillation, which may have precipitated the heart failure. Troponin is useful for diagnosing acute coronary syndrome and NSTEMI. Mild elevations in the troponin may be seen in patients with heart failure with no evidence of myocardial ischemia. BNP is a test which is not clinically useful in the emergency department setting. Acute pulmonary edema is a symptom, and when present, one needs to look for an underlying cause and treat for this. Symptomatic management of acute pulmonary edema is with supplemental oxygen and non-invasive ventilation such as CPAP or BiPAP. You will also need to reduce preload and afterload with the use of nitrates, and diuretic therapy is only useful once afterload reduction has been achieved. Pulmonary embolism. Patients with PEs present with pleuritic chest pain and shortness of breath. They may also present with syncope or hemoptysis. Signs on clinical examination are usually non-specific and can include tachypnea, tachycardia, fever, shock, and right heart failure with elevated JVP, RV gallop, and heave. They may also present with signs of a DVT. The first thing to do in the workup of a patient with suspected PE is to risk stratify the patient using the Wells criteria for PE. In low-risk patients, you can also use the PERC rule to rule out the PE. Patients who are low risk and PERC positive or intermediate risk should have a D-dimer performed. If the D-dimer is negative in this group of patients, then PE is ruled out. Patients who are high risk or have a positive D-dimer should have advanced imaging to rule out the diagnosis of PE. And this can be with the use of CTPA or a VQ scan. The treatment of PE is largely supportive with oxygen therapy if they're hypoxemic. Patients with hypotension should receive intravenous fluids and vasopressors if there's no response to fluids. Patients with a PE should be commenced on anticoagulant therapy. This can either be heparin or a low molecular weight heparin, followed by the commencement of warfarin. Hemodynamically unstable patients should be thrombolized, and if there is a contraindication to thrombolysis, the patient can be referred to cardiothoracic surgery for consideration of open thrombectomy. So in summary, patients with shortness of breath should have an initial assessment to determine the cause of their presentation. At the same time, an assessment of the degree of respiratory distress should be made, as patients with severe shortness of breath need to be aggressively managed. In the initial stages of resuscitation, you need to focus on supplemental oxygen and ventilator support if required, and these patients should then have directed therapy specific to the presumptive underlying cause. Patients with minimal respiratory distress can be generally managed on an outpatient basis, but patients with moderate and severe respiratory distress should be managed in the hospital setting.